Recording. All right. Well, we're off. So everybody, I'm Linda Flynn. I'm a consultant working here with PCLP. I want to welcome you to today's webinar, which is the 2013 Kickoff webinar. And we are on a very tight time schedule, so I'm going to keep snap to it, and I'm going to give my head over to our esteemed director, Dr. Esther Dyer, just to say a few words of introduction, and then I'll hand it over to our moderator, Dr. Merle Cunningham. So thank you and welcome. Hold on just a moment.
Good afternoon, everyone, and welcome to, as Melinda said, our kickoff event. I want to congratulate all of those on the video today and those who are with us on the phone. National Medical Fellowships was founded in 1946 when there were no residencies for African American students, and since then we've funded 30,000 scholarships. What I'd like to do is to welcome all of you and our partners. We are enormously grateful to the GE Foundation for its support of the program, and this is the second year. We will be in 8 states, 8 cities. We are delighted to have the opportunity to partner with 16 community health centers. There are 62 scholars, 50 medical students, nursing, and 6 physician assistants this year, representing 43 institutions in 24 states. Faculty advisors, and there are 25 of them, represent 15 institutions and universities. Most of all, I'd like to express our thanks to the National Advisory Committee, to our chair, Dr. Jack Geiger, who can't be with us, and to those of our members who are able to participate in today's kickoff session to set the stage for this year's program. And a special shout out to Dr. Merle Cunningham for hosting us. Thank you. Back to Melinda.
Okay, thank you, everybody. I'm back, and I'm going to turn it over to Dr. Cunningham, who is our moderator today, for whom we are eternally grateful. Merle, it's yours.
We're going to say a couple of housekeeping things in case anybody has any questions or about.
The only housekeeping things you should know is that I have muted everybody on entry, which is just a standard protocol, so we don't hear background noise. When it's time for Q&A, I will unmute you all. So I will let you know when that happens. But otherwise, I will be here. You can send me questions on the chat function if you need to. But otherwise, again, I'll turn it over to our moderator. We're going to keep it to 60 minutes, so hopefully we'll have some time for Q&A. But thank you very much.
Hey, everyone. My name is Merle Cunningham. I'm the pleasure of serving as moderator for today's session. We have a full agenda for today. I'd like to start off by welcoming everyone. We will be hearing from a couple of faculty advisors, someone who has a net perspective on this, as well as a scholar from last year, before moving into the question period. May I recommend that if you have questions that come up as different panelists are presenting, if you could type them in so that Melinda can follow them. So many people on the call, that would be the best way to organize the questions at the period during the end. We'll not be entertaining questions after each of the presentations, just for mechanical and logistical reasons. I'm pleased to be with you today. I'm actually one of the first physicians trained in the community health center setting back in the 70s at the Martin Luther King Center with Montefiore Center in the Bronx. Has been involved in one way or another with community health centers. Just wanted to say a word of the background of health centers. We will be providing you with the reading material that you'll have access to through the internet, so that you'll have an opportunity on your own time to a little bit more about the history of the health center movement and its origins in Africa and the field of community-oriented primary care. We also have on the call Dan Hawkins, Senior Vice President for Policy and Research at the National Association, who will be available to say a few words in welcoming you at the end of the call. Right now we're on a mute for the entire group calling in, so we'll unmute Dan at the end. So for those of you that may not be familiar that much with the history, briefly, the community health center world as we know it evolved out of the poverty program in the 60s, the Office of Economic Opportunity. Several centers were funded at that time partly to provide employment in the different communities and partly demonstrate the value of having services provided in the communities directly rather than in the hospital outpatient departments and public health services at that area. It's an important perspective for you all to develop throughout this summer that from your point of view and from our point of view, the community health center is really often the center of a system of care, although the different connections may or may not be well developed. You'll be getting experience with centers you're working in terms of how well they're developed, but the point is that the community health center is the focus of primary care, first access for people in the various communities that we serve. And primary care, of course, is for children, prenatal to adult, seniors, birth to death, people of all ages. And all of the centers also have oral health, dental services, as well as behavioral health services of some kind. There's quite a bit of variation around the country. Each of you will be experiencing that. And some issues relating to that will be covered in the webinar series that we offer throughout the summertime. It's important to keep in mind, however, that this is not the entire health system. The critical role played by hospitals and emergency departments, inpatient services, and special care is equally important, although those relationships are quite variable across the country, and each of you in your own center will be learning what the issues are with respect to those kinds of coordination points with other parts of the system of care. The nature of health centers, of course, is that it takes care of all folks unrelated to their ability to pay. With commercial insurance, a few, mostly Medicaid, but 30 to 40% of all of the people in health centers around the country may not have any insurance. They certainly change, or will certainly change, as health reform rolls out and the insurance exchanges develop further. We expect that we'll be able to provide some information to you over the course of the next 2 months so that you'll better understand a little bit more about the complexities of health reform sweeping across the country, the role of health exchanges, and how that directly relates to you and your respective centers where you're going to be doing your summer projects. I could just cover briefly some of the key characteristics of community health centers, just so that you can fully appreciate that. Basic characteristics that are in the statute and in all of the guidelines and make our community health center world quite unique with respect to the world of private practice. These centers are all located in designated high-need areas, urban and rural areas, through a designation process, which is fairly complicated. Some of you may have an opportunity to learn more about that, but if you're not familiar with it, you should at least ask when you're at your centers. The second characteristic is that these are all of the programs offer a comprehensive care. As I mentioned before, almost everyone offers services, behavioral health services, and a wide range of enabling services to help people better navigate the system and to get assistance with whatever the issues are that relate to their families in the neighborhoods they live. Another unique feature is that the centers are there to take care of all, regardless of ability to pay, as I mentioned before. Some people may have insurance, some may have Medicaid, some may have commercial insurance, but a sliding fee scale is required to be in place for all of those who do not have some kind of a health insurance. And you'll learn more about that, but this is unique because this is the only part of the system in the United States where there is the ability for people who don't have insurance to currently get care. Additional unique feature is that all of the health centers are governed by boards. This is part of the legislation. This is a true evidence of community control where the governing body of the health center must pay 51% of people from the community that are registered and actively use the service. All of you will have an opportunity to have some interaction with your community board throughout the summer experience. But again, this is quite unique and the only place in the country where this is truly a community-controlled health service operation. Last basic characteristic, which is also somewhat unique, is that the centers have quite strict performance and accountability standards for both administrative, clinical, and financial operations. This was the first part of the health system in the entire country that had rigorous performance standards and measures going back to the 70s, actually, when this first started. So it is quite unique in the country that these centers have this kind of accountability built in. Centers are often known as federally qualified health centers, FQHCs. You'll learn more about that in the course of your summertime. All of the centers receive some level of federal funding that may be as low as 5, 10, or 15% of their overall budgets, and some that may be 40%. But all places rely somewhat on their federal support, maximizing revenue from other places. And on a final note, I'd like to just comment that from surveys done by the National Association, at least a third of all the centers in the country have some type of health professions education actually on site, whether it's medical students, nurse practitioner students, PA students, and approximately 80 now also have residency training programs as part of their operation. So the center has for many years been directly involved in health professions education and teaching. And each of you will have a very valuable experience in your team setting in those centers. The basic flow for the remainder of the we'll be hearing from several faculty members, a couple of faculty members, and then Kathy Westfelling, who has national perspective on this, and from one of our prior scholars who went through the program last summer. And then we'll have questions available. So at this point, I'd like to turn this over to Brian. If you could move the slide, Melinda, so that Brian's comes up here. So Brian, take it away.
Okay, are you able to hear me okay, Melinda?
Yes, I can hear you. Go ahead, Brian.
Myself. It's great to have a chance to talk to everybody. Hi, Merle. So I thought that I would spend a few minutes just reflecting with all of you a little bit about what it means to step forward and decide to be a leader in the healthcare profession. Congratulations to all of you. We're also excited that you've made this commitment. And over the course of my career, I have reflected a lot on what does it mean to be a leader. And the definition that I've come up with is someone who is deeply concerned to the point of action. And all of you have taken that first step of action in joining this fellowship and joining a community of leaders to receive some mentoring and a great experience out in the community clinics.
Can I ask Brian to look into the camera while you're talking?
Oh, sure. Am I looking into it now?
No. The camera, now you are. Yes. Okay, thank you.
Better? Okay, thanks. I was going to say that healthcare in America is changing quite dramatically, more than ever has changed in the history of the country. With the passage of the Recovery Act and the Affordable Care Act, this healthcare system is finally going into a direction of true integration. And what you'll find as you talk to other healthcare professionals across the country about these changes, you'll find that many people are afraid of change. And actually leaders who are needed to step forward and actually take on change and welcome it rather than step back and take more of a tentative approach. So this is a great time for you to be stepping forward as leaders. There's a long history of an ethical foundation in American medicine that is probably familiar to all of you. And as you've entered your respective professions, I think that you all had an impulse to care for others in the community with what we would call beneficence, always doing the best that you can for your patients. Non-malfeasance, always doing everything we can to avoid harming our patients or to prevent harm from coming to them. An ethical concept called autonomy, which some are familiar with the idea of patient autonomy and making sure that your patients are free to choose the kinds of therapies that they would like to have. But also there's a notion of provider autonomy, being free from constraints that might lead you to encourage your patients to do things that are actually in their best interest. So the physician or provider autonomy is also very important. And lastly, there's the social justice piece, the notion that everyone in our society deserves to have access to excellent care. And I think that's probably what drew so many of you into this fellowship. What's interesting is that these ethical principles have been with us for many thousands of years. And for instance, back in 50 BC, Cicero said, men were brought into existence for the sake of men, that they might do one another good. Later, in the Hindu wisdom literature, there is a quote, children, the old, the poor should be considered as lords of the atmosphere. And finally, the ancient Jewish wisdom literature, Leviticus 19:18, many of us in the U.S. are familiar with the phrase, love thy neighbor as thyself. So it is this long wisdom tradition that has led to the beneficence, non-malfeasance, autonomy, and social justice core principles that we as leaders have committed ourselves to upholding. Now, the question is, what is evidence with regards to how we provide excellent care to our communities? And the short answer is that everyone needs to have access to excellent primary care. Barbara Starfield and a number of other scholars have developed quite a bit of evidence that this is the case. And a model has developed over the last decade called the patient-centered medical home that many of you have probably heard of. Dr. Starfield identified 4 pillars of primary care that we should be put in place in our community clinics in order to be certain that everyone in the community gets the best care for less cost. And those 4 pillars, I'll just review them with you briefly because I'd like you to reflect on them in the course of your fellowship. The first is personal relationship over time with their clinician. And achieved this in 2013 by electronically impaneling patients to individual providers, but also to care teams, because care is no longer delivered just by an individual provider, but we know that care is valuable when it's provided by a team. Second, access. Patients need to have excellent access to the right care at the right time when they need it. This is actually a very complicated process and something that I hope you will reflect on during your time in the community this summer and talk to your mentors about. The pillar is that care needs to be comprehensive. And that's where, as Merle mentioned, we start with the woman contemplating pregnancy through pregnancy, caring for young children, adolescents, adults, and finally the elderly and those who are experiencing end of life. And so the care must be comprehensive. Any community care center that hopes to provide true value to the community. Lastly, care must be well coordinated. So as you look at your different community centers that you have an opportunity to interact with, I'd like to think about these 4 pillars of primary care: relationship over time, access, comprehensive care, and coordinated care. And speak with your mentors and your colleagues about how they have about embedding these 4 pillars in the community clinic. I again say that we're pleased that all of you have stepped forward as leaders at such an age in your training. And remember that leadership is difficult. You will, as you lead through the years, you will often encounter resistance to change because people are afraid of change. By working with a community of innovators and a community of leaders and really paying attention to the science behind what we're doing, we can find a lot of confidence and a lot of will to persevere in the name of our patients and in the name of our community. And talking to you, and I'm looking forward to getting a chance to meet you over the course of the summer.
Thanks, Brian. The next panelist is Dr. Tenori from the Family Medicine Department at the University of Mississippi. Take it away, Dr. Tenori.
Hello and greetings this afternoon from Mississippi. I congratulate all of you on choosing to take this summer program, and there have been given a lot of the specific things for leadership and the primary care medical home. Some will offer an opportunity that is different from basic medical school education in that you will be reading out at an earlier time period to see a lot of the variables that are involved in delivering the best medical care to our population. Things that you will be able to experience with your community health center and your project that you will be working on is helping us to identify some of the resources we have, resources we need, and accessibility that we can arrange for to better accommodate the care of our patients. Your projects are valuable in that they do often spur us into going further than we have been going in delivering our health care to the best way possible for our patients. Some things that you will encounter may not be what you consider your basic medical education, but they are part of the practice and art of medicine. Those will involve the relationships that you will have with the patients that you see. You will have an opportunity to have repeated contact with the same patients. Have interactions with community leaders and how they affect our delivery and help us. And we'll have interactions with what community needs to the point that you may offer classes for education. Some places lead exercise. Some places grow a garden in order to provide the best nourishment for the patients, because that is a basic necessity in prevention, maintaining good health. I hope that you all have a good time, that you have open minds. Your mentors are available. If you are in an area that you're not used to being in, contact us and we can all give you directions and different for things that you can do to help make your stay the best possible. Thank you. That's it, Merle.
Hey, this is Melissa. I don't know if we've lost Merle, but thank you, Dr. Tenori, for telling us today. Actually, I believe that Kathy Westfelling is going to be next. You on the line? Can you be on the webinar?
Kathy, not on the line?
There's Merle. Hi, Merle. We couldn't hear you until now. Okay, I'll let you get back to your moderator role. I'm not sure that we hear Kathy anymore.
Okay, can you mute Kathy?
She muted on my end, so I'm not sure. Maybe it's something on her end. I'll switch for a moment and go to Italo if we to be flexible.
Let's do that. Italo Brown is a medical student at Meharry. He was a scholar program last summer, and Italo, we'd be delighted if you'd share with some of your experience with the folks and let them know what to expect this summer. Okay, Italo.
All right. Everybody hear me?
We can hear you, Italo. For some reason, your webcam isn't working anymore, but maybe you'll come back up here in a minute. So, details, but we hear you at least. So
I think I got it now.
Deal.
Okay, so my name is Italo Brown. I'm a second-year medical student at Meharry Medical College. I like to say rising third year because in about a month I will be starting clinic rotation, so that's pretty cool to me. But give you a general scope and to keep it within the time constraints, I think that this is a tremendous opportunity for people who want to grow into better care providers. It's often you come into medical school, you are going to be a good physician, but there's very few things that are elucidated as far as how to go from being a good physician to being better or a great physician. And I think that this is one of those things that's a segue. I know that applying and trying to figure out, is this something to do? I asked myself several questions, and one of the questions was, do I know what patient-centered care is? Do I understand what it takes to run like a community health center or anything like that? And these things were extremely interesting to me. So it's kind of like a no-brainer when you see that the curriculum of this program facilitates that learning. You can kind of you can grow into it. You can be more organic in the program. And then I like the fact that there were things that I could control, like I could pick my project as opposed to what some of my classmates were doing, which they were just linked with a researcher for the summer and doing whatever the researcher designated. So that's refreshing. Things that I really liked, especially my experience, was I kind of got I call it grassroots medicine approach, where you're not just inside the four walls of a hospital or the four walls of the federally qualified health center. You're on the ground. We had the opportunity to ride around in a mobile health unit, and that's kind of like a big RV with a doctor's office on the inside. And I got a chance to see patients who had never been seen before, overcoming their barriers just to step out there and get blood pressure checks and glucose checks, lipid things that we would consider very basic and rudimentary care that they hadn't received. So that experience alone was enough for me to kind of feel satisfied and to talk to my classmates and really impress upon them the need to step into those arenas and to know that it should extend to anybody. It's not just for those who can afford it or for those who have to be linked into a certain system. We've got to take it upon ourselves as oncoming care providers to seek these individuals so that they don't fall through the gap. Am I good on so far?
From my perspective, keep going.
All right. To give you some insight on things that I did, I worked with at my site, he had a very comprehensive layout for it. He had us for some weeks working with the nurse staff so we could appreciate how entire clinical care team ideal works. We've showed and followed, well, not shadowed, but we showed and did work of a CMO for another set of weeks, and then did clinical rotations with the on-site clinicians. So I got all three experiences, and it informed perspective of delivering care. Things that I specifically liked was, I was doing this entire project around the time where the Affordable Care Act ruling was being decided. So I got to see how on-site people were about a positive ruling. And, that was one of the most, vitalizing things, to know that people really wanted that to happen and they wanted to see the care upheld. Now, there are other opportunities where I got to do some scheduling, scenarios. So at my site, they gave us the opportunity to, it's like a medical problem. Well, not a medical problem, but like a problem. And they said, we have this many staff members, this many clinicians, and the demands of the clinic for a month. Tell us how you would fill that. That's just something that as a medical student you never think of, because you're always funneled in on the side of being an extra hand. But you put in the driver's seat where you have to make the decision. You have to kind of move the widths around or the pieces around to make it fit, and to know that it's not always going to fit. You got to find innovative solutions. That's something that I think put me a different realm of understanding of our healthcare system. So would just advise you all that as you approach your different sites and get into the ideology of the program, buy into the leadership or the mentorship that you have there, and then push yourself to really to think outside of the box, to grow on a weekly basis. Even though you're doing all of these reviews or like updates, push yourself to see the things that weren't as obvious. Report a case that you think may have been one of the more defining things of that week, and continue to reflect on that. So I've been reflecting for the past year, and I think that it's really made me a stronger medical student, a stronger problem solver, and a little bit more prepared to enter this modern world of healthcare delivery that's about to happen.
Thank you, Italo. We have Kathy on the line, at least on the audio, so our next will be Kathy Westfelling, who's had many years of experience in helping design and manage interdisciplinary team projects such as the one that you're about to go into. So, Kathy, are you there?
Hold it down for a minute.
Kathy, are you there?
Can you hear? I'm here.
Oh, we can hear you now.
I had to hang up. I lost the connection, so I redialed.
Okay, but this is Melinda. I just want to say one thing. In order to make Kathy's audio work, I unmuted everybody. So if you could physically, manually mute yourselves, that would be appreciated, just so that we can hear Kathy. Thank you.
Thank you. First, I want to add my congratulations to all of you on the line who are ready to embark on this wonderful community-based experience. I actually always look forward to this time of the year when I worked at the American Medical Student Association, where my students went out every year into community-based systems of care. A lot of the comments I was going to share with you have been made, so I'd like to spend a few minutes really talking about what we, the Association of Clinicians for the Underserved, call the transdisciplinary model of care. And that is, we really believe that the patient benefits most when people share knowledge and skills with trust and respect across the disciplines. My message in that is that wherever you are, whatever health center, I encourage you to really make time to get to know the other clinicians, the other members of the staff, and get to know how they're trained, get to know their viewpoints on the community and the patient. One of the things that I've always valued in the community health center model is, in many cases, the people that they hire are from the community. Some of the best learning experiences you will have are with your community health workers and your medical assistants, who really are the pulse of that community and know how they work, how decisions are made, and they can tell you who the key decision makers are in the community. If you're able to make appointments with those people, go out on home visits, visit community organizations that they're a part of, I think this will give you a great opportunity to understand why this community hopes that you will choose to be a primary care clinician in that community. As we look to the primary care needs of next year and beyond, we're overwhelmed with how many of you need to make the decision to work in community-based primary care. So from a national perspective, I hope the health do a great job of not only looking at you as a future clinician, but that you too look at community-based systems of care as a very positive place to work. When my students met with CFOs and chief executive officers, their role was to really explain how the health centers are funded, how they're organized. Meryl gave you a little overview of community boards. You meet with a community member of the board and get to know their feeling of how patients are treated, incorporated into your clinic. In terms of the overall layout of a health center, you should leave the health center without knowing something about oral, behavioral, pharmaceutical services and how they're delivered, either as part of that health center or contracted out into the community. Nothing that we do now around chronic disease management can occur without really good care coordination, integration of pharmacy services, medication reconciliation. These are all terms you're going to hear when you walk into that health center. And put a face to who those people are that make those services come into reality with the patient.
Can I interrupt you again? This is Melinda.
Yes.
I just want to jump in and say that some people are still not muted, so if you could mute your phone, I have some background noise. I'm working on unmuting you from this end, but while I do that, if you could do it yourselves, I would appreciate it so that we're not interrupting Kathy. Thank you.
Okay. The other thing that's going on in health centers at full force is the use of electronic medical records and the transformation of our health system to use technology. So I encourage you to get to know who are the leaders in the health centers looking at the role of the electronic medical record and also mobile technology. Are they using cell phones? Are they getting involved in tablets? Get to know how that works. Who's training them? What are the leadership roles for people like yourself if you are really into health information technology and like all that tech? That's evolving in health centers big time, and they always need a champion, regardless of your discipline. It doesn't have to be the physician. In many cases, we have nurse informaticists evolving in health centers who really are the people who are taking leadership for the use of data and how data is actually telling the story of quality in our community health center systems. The other thing that's unique to our health centers is how much they do around language, culture, and literacy. You will meet many patients for whom English is not their first language. And so seeing how they have adapted their health system to accommodate people for whom English is not the first language, or even people for whom literacy is a challenge. Are they getting on written word? Are they looking at audio and visual presentations? Look at the environment you work in every day. Have there been adaptations made so that people with other languages, other cultures feel comfortable in that health center? I think health centers, for the most part that you've been asked to serve in, have done a good job with those issues. But make a point of looking around yourself and seeing how people of other cultures are comfortable in the setting in which you're working. The comment I want to make is we're very aware as you folks are making decisions to be primary care clinicians in our community-based systems of care that your level of debt impacts you. Talk to health professionals at the site where you're located. How have they been managing their debt? Are they part of loan repayment programs, whether state programs or our National Health Service Corps loan repayment program? Get a sense of how that can be managed and how they have made decisions for themselves and for their families. It's going to affect you, and you need to start planning now. If this is a career that you want, there are ways to manage debt, and there are people out there to help you look at that in the long run. Those are the major issues from a national perspective I wanted to talk about. But just for a minute, your special project is something that Meryl asked me to spend some time on. I'm actually a public health nutritionist by training. And one of the things that I really valued when I placed students was how much they really gained by being involved in health promotion and disease prevention projects. Excuse me, several other speakers made mention of community gardens or going out in mobile vans. Make sure your project encourages you to meet with people in the community, but also to ask that you be supervised by someone different from the preceptor, the person you're shadowing time with. Oftentimes, the skills that you will need for your project are different than your primary care clinician. So being able to work with a nutritionist, a nurse educator, a diabetic educator, someone who's really looking at data analysis for the health center. Get to who they are, what their skill sets are, and I think your project will be enriched by that teamwork that you will have with that person. And you come back and bring that set of projects and accomplishments back to your preceptor, reflect with them on how important it is that you have these members of the teams to work with in the future. And I think pretty much those were the comments that I had wanted to share with all of you, and I look forward to hearing about your summer and reflecting on your papers at the end. Thank you.
Thank you, Kathy. Merle, are you still with us? Oh. Looks like I've lost Merle, but that's okay. I'm here with you. I have a question. I think at this point we're going to go to some Q&A, and I have been sent a question, and this really goes out to all of our panelists, any of our panelists. So I am muting our panelists as we speak, the ones who are muted, so that any of you can speak up and answer this question. I have a question from Lauren Yu, who says she has a question about residency programs. It says, I have heard from a few fourth-year medical friends that their primary care community care program is not well known. It's always been my thought that community care programs, well known or not, provide the best training for this type of work. What is the benefit of attending a large research center versus a program focused on community care? Will one be prepared to see lower income patients if trained at a large center? Our panelists want to tackle that.
I'll speak to it. This is Faith.
Hi, Sis.
Hi. There are several different forms of residency programs that are available for primary care training. They all have aspects of being able to reach out into the community. Even some that are associated with academic health centers are also called community-based, but your clinics are usually outside the ivory tower, so you will deal with care from the community, more so just the tertiary referrals. But that's a good question to consider. Part of what we teach in residency in family medicine, since that's the one I'm familiar with, is how to relate to the patients, how to consider their social, economic, and behavioral components, how to learn to prescribe affordable medicine so that they're not compliant because of their inability to maintain the access for what you're prescribing. So these are all components to look at as you investigate residency programs in your fourth year. But there are good questions, good components, and ask at different programs what is available for that. We also a lot of times staff free clinics, so that gives you another opportunity to work with those who are without.
Great. Anybody else on our panel want to address that? Thank you, Thais. I do have a question that was directed to Italo. Italo, are you still with us?
Yep.
Good. All right, terrific. I think I have your video might not be on, but that's okay. The question that directed to you was, what a normal day or week like for you during the program? And that question comes from Joseph Krakowak, who I probably just slayed his name. So my apologies. What was a normal day or week like for you?
I'm at a neighborhood health services site in Nashville. I go to school in Nashville, so it's kind of convenient. One day would start off, depending on the week, usually around 9 o'clock. I would come in and we'll brief with the board at that time. I also had a partner that I was working with. In some situations, we would have meetings scheduled for the first maybe 2 hours of the morning. So you usually have, I guess, a Wednesday or something like that. There's usually a team meeting, or there's individuals from the community who want to meet with the hospital to kind of create some program. Those things occur mostly in the morning. There was a component where we would go out into the community throughout the day, usually in the early afternoon, and in the evening, or not the evening, but the afternoon is when we would work on our individual projects. On clinic days, it was 7 o'clock in the morning, going there, and then really just trying to get as you can get done by following the clinician, and almost as you were on rounds or something like that presented. Days where we shadowed the CMO, but early as well, but we're a lot more integrated. We would travel from one site to another site in one day. You maybe 4 site visits as see patients. So we would have a schedule where he would see patients in the morning and do site visits in the afternoon, or flip-flop. So that's kind of how it would go. And then the week pretty much would be any arrangement of that. So if I was following a CMO for the week, it would be that for the week. But in general, like most days, I was done around 5, like a regular job. I had plenty of time to go home and read things and read up on other stuff. There were downtimes throughout the day, and a lot of conversations offhand were good, like talking to people who were interning, other medical students, other nursing students. That was really helpful to get their perspective on not just the program, but on what they do on a day-to-day basis. So I hope that answered your question.
Thanks, Paolo. I want to let everybody know that I went ahead and unmuted you for these last few minutes of our webinar, just to allow you to ask questions verbally. But if you don't have a question, go ahead and mute yourself on your end. That would be appreciated. But I went ahead and unmuted you so you could speak. I know that Merle is trying to get back on the call as well. He's having some phone difficulties. I'm not sure what they are. I am getting a chat, though, a question from Christopher Hillhouse. Are the projects limited to the ones listed in the email, or can you create your own? And Christopher, I don't know if you can hear me, but I'm not sure exactly what you're talking about with the projects. Probably, I'm guessing that's probably something that would go to one of the other staff members here for a question. Maybe your preceptor here, that would be Sam or Jessica. So. I do have a couple of text questions that are coming in, actually, now that I've unmuted everybody. I will read them. These are for our panelists. There's actually another question for Otello. Obviously, you're in demand today. Would you say that your day-to-day experiences were more like similar, or were they more hands-on? I'm not sure if that was, I'm guessing you got auto-corrected, Emily. I'm not sure that that's really what you wanted to ask. But that's what it says.
School, I'll bet.
Like school. There we go. That's different.
Okay. All right. So, can you hear me?
I hear you.
They were at all like school, and I didn't have the most experience at the time. I was ending my first year of medical school. Before that, I was a researcher, and before I did public health. So it was unlike any of those experiences, other than the fact that I was physically in a hospital. That's the only way you can say, all right, there was parity. I thought that the things that stood out, or not stood out, but that were more, I guess, distinguishing was that more hands-on learning took place, more real-time learning. So it wasn't just like, okay, learn about hypertension, and then you go home and read about hypertension. It was like, no, there's a patient in there that has hypertension. We're going to see her. We're going to come out, and then we're going to discuss hypertension. And then I'm going to tell you about the program that our center does for people who have hypertension. So it's like you get the continuum of care, not just, all right, the isolated disease model or whatever it is. So I thought that was one thing that was different. And then the other thing was really just kind of being looked at not as a, when you're shadowing or when you're in a preceptorship, you're kind of like the hands-on deck minion. In this situation, it wasn't like that. It was like they knew we were there. They wanted us to feel like junior doctors. So you get the same level of not respect, but the level of appreciation and energy that position who was staff. At least where I was at, that's how I felt.
Great, Otello. I have several questions coming into me now. I am going to read one. Let's see. These are actually more programmatic questions. I'm seeing there's one from Carla, one from Stephanie about these are things that you would direct to your preceptors here at the PCLP office, questions about your project and about your schedule. I would encourage you to follow up with Jess or Sam over here in the office. So, and I'm looking through my texts, and I think I see all the ones, or I think I've addressed all the ones that have come in so far. So, any other questions, I encourage you to send them by text. Again, using the Q&A here, the chat button. Does anybody who is not muted to ask a question? Overall?
Hello, can you hear me? Cherry Whitehead Thompson with East Arkansas Family Health Center in West Arkansas.
Cherry.
Hello.
Did you have a question?
I do. So, the students have to be directly supervised by MDs only, or can they also shadow or work with APNs or PAs?
Also sounds a little bit like a programmatic question. Some staff members here in the office saying that you can email Jess or Sam about that.
Okay.
Or email Dr. Jones about that, actually. And she'll address that for you. I think that would probably qualify as a question for Joy.
Okay, thank you.
You got it. Anybody else who is not muted want to ask a question of our panel? So I have a question coming in from Lauren Yu right now. About establishing a federally qualified health center. How does one go about proving need in a community to qualify for a grant for an FQHC? Who can address that on this call? Kathy or Brian? Well, if you're back on, Thais, do you happen to know how somebody goes about qualifying for an FQHC establishment?
Will you hear me?
I can. Hi, Brian.
Hi. Actually, it's a fairly complicated process that you can read about if you Google FQHC. There are a couple websites that you'll find right away. They're pretty helpful in helping to explain the process. But essentially, you have to be able to collect data to demonstrate that the area where you want to open up your clinic is an area that has a service need. Not interested in subsidizing new clinics in an area where they feel that the number of FQHCs that exist in that area are already able to meet the population's needs. So that's the primary. I'm not expert enough in the process to give you a lot of gory details, but it has to do with assessing the need of the local community.
Thank you, Brian.
Another thing I'll mention that many of you may be aware is that there are two different kinds of federal qualified health centers. The one the most difficult to obtain in terms of recognition is the QHC that receives a large grant, a large startup grant of about $650,000. However, there are a lot of clinics who are able to get what's called look-alike status for FQHC, and it's something that you can ask the administrators at the FQHCs about the difference between fully funded FQHC versus look-alike status. There are a lot of existing community clinics that in the decade their boards have recognized the advantages of becoming an FQHC. And if they're not able to be recognized for grant, they can still have all kinds of very significant benefits from being a look-alike. The most significant benefit is what's called the cost-based reimbursement. And that's what you do accounting to demonstrate to the person, CMS ultimately, how much it costs you to care for one patient in your clinic. And you then may receive a cost-based reimbursement Medicaid patient based upon that cost. So, for instance, instead of being paid a typical Medicaid rate of maybe $14 to see a patient, you may receive something like $200 or even more. So the cost-based reimbursement is available to those who have only look-alike status, and as you can imagine, it really helps a lot to subsidize care for those who have no payment behind them whatsoever. And then also you have access to wholesale medications so that you can dispense medications at a much lower cost to your patient population. And finally, you have access to the malpractice that's available through a national organization that makes it very affordable for you to insure your providers for malpractice. I hope that helps a little bit.
Thank you very much, Brian. I appreciate you answering that. I have a couple more questions for Italo, if you're still there for me.
Yep.
Great. All right, I have a question. Actually, I'll just do this in a two-part question here. How did the patient population respond to you, and would it be possible for you to tell us a little bit about your project from last year, just briefly?
Okay, so I will try to tackle both in a succinct thought. So my project from last year was more of a needs assessment / evaluation of existing programs that they had at that site. Specifically, I looked at the diabetes program that they had there, and they had a hypertension program that was kind of rolled into it. And going in, we had spoken, we talked about the things that were working for the clinic and the things that weren't. So using a little of my public health background and really trying to hunker down on what the needs of the patient population they did see were, I tried to give the best, of what could make it better, what could make it more efficient. And we kind of settled on some ideas regarding use of their SNAP cards and creating literature around how to use SNAP cards. I don't know if everybody knows, SNAP card is essentially like food stamps, but it's more now. So the use food stamps to healthy meals instead of these are the stamps and I can here and buy whatever I can or manage those. But that said, the way that I kind of dealt with, or not with, but I worked with the population. I think that's easy. I go to a school where we see people who most would consider indigent population. I think that the majority of the folks that come in don't have insurance or underinsured or are looking for some type of solution. And all it really takes is just that level of cultural competency that was spoken about earlier and understanding that everybody deserves care. So as far as the patients that I fielded, I just took it from the first semester of medical school, like just in my history, my patient history, and really tried to be a conversationalist in that regard, like not coming from a cold stance, but really trying to engage them. Because unlike the clinic, most of the time, you get more than 10 minutes to find out the problem. You have a little bit more time. It also depends on the site that you're at. So you have high volume, and that may kind of impinge on things. But at the sites that I worked at, we had enough time to really ask questions and get down to maybe some more personal things and allow the patient to reveal stuff that helped with creating a treatment plan. So, again, dealing with the patient population to me is more of a testament to your ability to practice cultural competency and linguistic appropriateness. And the good side of it is every day you walk in there, you get another shot to try it again. So that becomes the baseline for me.
Thank you very much, Talo. I am going to unmute everyone right now. Just say that again, but I'm muting you and unmuting you as this goes on. But I'm going to unmute everybody in the hopes that one of these callers is our esteemed Dr. Cunningham. Are you on this call right now, Merle?
Can you hear me now?
We can. There you are.
Well, I dialed 3 times. Obviously, I can't get in if I'm not unmuted, so I've been living for the last half hour.
Well, I apologize. It's definitely, you're not shown up as Merle. You're shown up as caller number something, so because you didn't call in with the registration. I apologize for that. But Merle, I believe we're down to the last few minutes. Do you want to say some closing words for us?
Ian Hawkins, are you still on?
I'm right here, Merle.
Oh, terrific. There's Dan.
Dan, say a few words. For the National Association of Community Health Centers, this is the national group, and Dan has been with the program for many years. And sorry for having you muted so long. So would you say a few words to our esteemed group, please?
That's quite all right. I like to think you saved the best for last. Well, first of all, I just want to welcome everyone on the call and every one of the students and fellows who will be spreading out to health centers across the country. You've already heard of the proud history of community health centers, born of the civil rights and war on poverty movements some 47 years ago, and today the health care home for 22 million people, 71% of whom are poor, 36% have no health insurance, 63% people of color. And health centers carry forward the proud mission to expand and enhance care as to high-quality, community-responsive care for all. I really appreciate what all the remarks that Brian and Thais and Italo or Talo and Kathy have provided. It's you've got full picture now of what you're going to be stepping into, and we hope that your time with the health center and your experience leads you to choose a career in community health. Serving and working with communities side by side to improve the overall health of the community, both in terms of individual patient care and in terms of community-wide care. That's consistent, fully consistent with the mission of health centers since their founding, and I wish you all the very best as you go forward in this great experience you're about to have. Thank you, Merle.
One final comment. For those of you that are interested in learning more about what the residency training opportunities are for medical students or for continued study for PAs and practitioners, please contact the offices. We will put you in touch with residency programs that are based in community health centers around the country so that you could pursue those. Whoever's near you or near a place that you want to be. But again, we have around 80 different centers in the country that have residency training programs, part of them. So there's an enormous number of opportunities now for those of you that really want to go on into your residency, medicine, pediatrics, internal medicine in a community health center setting. Don't hesitate to reach out. We'd love to put you in touch with these places.
Terrific. Thank you, Dr. Cunningham, for that extra information. And Dan, it was nice to hear your voice again. Thank you for being with us.
Thank you, Melinda.
And to everybody who was on our call, thank you very much for being with us today, sending us your questions, and to our panelists, again, we're very grateful for your time and effort today, and that goes to Dr. Cunningham as well. And of course, we miss Dr. Geiger, who couldn't be with us today after all, but obviously he is with us in spirit. Thank you very much. I'll end the webinar.
All right, take care.
Thanks.